Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology and Urology at Seoul National University Hospital. In this session, I would like to share my experience of how we can use contrast-enhanced ultrasound in evaluation of indeterminate renal masses. Ultrasound is the most popular first-line imaging in evaluating renal masses. If we have any problems at ultrasound findings, contrast-enhanced CT or MRI usually can solve the problems. However, contrast-enhanced ultrasound may be an excellent alternative, especially in patients with impaired renal functions, because ultrasound contrast agent is known to be safer than CT or MRI contrast agent in those patients. Moreover, contrast-enhanced ultrasound is much more sensitive than contrast-enhanced CT or contrast-enhanced MRI in showing very subtle enhancement. This is an example case showing how sensitive contrast-enhanced ultrasound is. This is a 44-year-old man with end-stage renal disease. Non-enhanced CT shows a little bit high attenuated masses in both kidneys. Doppler ultrasound shows mixed cystic and solid masses with a small dot-like color signal that may be a true flow signal but also may be a twinkling artifact. In this situation, contrast-enhanced ultrasound will be the best option to determine whether this solid-looking area has blood flow or not. So bubble contrast was injected, and now you can clearly see the bubbles coming into the solid-looking area, indicating that this area is a viable tumor, not a blood clot. And we can make a diagnosis of renal cell carcinoma developed on the background of end-stage renal disease. And the kidney was taken out, and the mass was renal cell carcinoma of unclassified type. This case well shows how sensitive contrast-enhanced ultrasound is. CEUS of the kidney is different from CEUS of the liver because the kidney has single arterial system without intrarenal communications. And so objective quantitative analysis is possible with strictly blood pool ultrasound contrast agent. And it has much higher temporal resolution than contrast-enhanced CT or MRI. These are serial ultrasound CT and MRI images after contrast injection for comparison. With contrast-enhanced ultrasound, in addition to qualitative analysis such as presence or absence of enhancement rapidity, grade and washout, and vascular pattern and heterogeneity, quantitative analysis is possible from time intensity curve, including time to peak, peak intensity, and wash-in rate. This is a case of cystic clear cell renal cell carcinoma in this article. CT shows indeterminate low attenuated mass, and contrast-enhanced ultrasound shows enhancement of mural nodules and irregular septa, and time to peak of the nodule was shorter than that of the normal parenchyma. Several guidelines were published regarding the use of contrast-enhanced ultrasound, and the best renal indication of CEUS is evaluation of indeterminate renal masses. Now back to indeterminate renal masses. What is the definition of indeterminate? That probably means indeterminate between solid and cystic, between neoplastic and non-neoplastic, and between benign and malignant. Most important thing in this differentiation is presence or absence of enhancement or vascularity. There are two things we need to keep in mind. Number one, CEUS enhancement is different from CT or MRI enhancement in mechanism. Number two, positive enhancement or vascularity does not always indicate malignancy. Okay, so let's begin with indeterminate cystic renal masses. Bosniak classification is the most popular system in evaluation of cystic renal masses. It was introduced in 1986 by Dr. Morton Bosniak at New York University, who recently passed away. There were some modifications, and the current system is 5-class system: 1, 2, 2F, 3, and 4. Here you should understand that the Bosniak classification is originally for renal CT, but it can be applied to renal ultrasound or MRI as well. Description of each class is quite long, but basically, Class 1 is clearly a simple cyst. Class 2 is minimally complicated, but surely benign, and so no further follow-up is necessary. Class 2F is a little bit more complicated than Class 2, so follow-up imaging is necessary. Class 3 shows measurable enhancement of thickened irregular wall or septa, and Class 4 is clearly a malignancy because of enhancing soft tissue components. Class 3 and 4 need surgical treatment. I think more important thing is a common understanding among the reporting radiologists and the referring physicians regarding the risk of malignancy. There have been a lot of articles on this issue, but roughly we may say that the risk is 0% for Class 1, almost 0% for Class 2, about 5% for Class 2F, approximately 50% for Class 3, and 100% for Class 4. Among these classes, always the problem is differentiation between Class 2F and Class 3 because the risk of malignancy is very different, and so recommended management is different. Here you see a case of a cyst with a fine septum that does not show flow signal at Doppler. If there is any question regarding the flow signal, CEUS can confirm that there is no flow signal, so Bosniak Class 2. This is a case for comparison. Similar fine septa, but there are clear flow signals at Doppler, so this is a case of Bosniak Class 4 and was a renal cell carcinoma of clear cell type. One thing we need to be careful in assessing flow signals using Doppler is twinkling artifact. This artifact often occurs behind the stones or calcifications with rough surface and may mimic true flow signal, but can be confirmed as an artifact if we see bidirectional noise Doppler spectra. Of course, we can confirm that there is no flow after contrast injection. So this is a case of Bosniak 2 cyst with almost 0% of malignancy risk. Contrast-enhanced ultrasound is helpful when the enhancement is equivocal at contrast-enhanced CT. Here is a mass in the severely hydronephrotic kidney. There are areas of suspicious enhancement as CT. Contrast-enhanced ultrasound clearly shows nodular enhancement of this area, so it is a Bosniak Class 4 cyst and was a renal cell carcinoma of papillary type. This is probably the first article reporting the value of CEUS in renal masses. They did ultrasound after injection of carbon dioxide during angiography in 13 patients with renal cell carcinomas and 2 patients with benign lesions, and found that sonographic angiography is much better than conventional angiography in showing tumor enhancement. This is an article entitled Contrast-Enhanced Power Doppler Sonography for the Differentiation of Cystic Renal Lesions, published by our team a long time ago in 1999, using first-generation ultrasound contrast agent Levofist, and our conclusion was this imaging modality might be very useful in differential diagnosis of problematic cystic renal lesions. This is another article entitled Assessment of Cystic Renal Masses Based on Bosniak Classification, Comparison of CT and CEUS, published by our team in 2007. And the conclusion was, contrast-enhanced ultrasound might better visualize internal architecture and enhancement of some cystic renal masses than CT, resulting in upgrade of Bosniak classification and affecting their treatment plan. Here is a case of cystic mass with complex internal architecture, but Doppler ultrasound does not show definite flow signals within the internal solid areas, so it is difficult to assign Bosniak class. In this case, contrast-enhanced ultrasound can be very helpful in showing internal architecture and enhancement. After injection, enhancement of septa and solid nodular areas are well demonstrated, and these findings are well correlated with gross morphology of a clear cell renal cell carcinoma. Another patient with a cystic mass with a small nodular lesion and fine septa. Doppler ultrasound shows some flow signals, and contrast-enhanced CT shows equivocal enhancement, so we may assign Bosniak class 3. But after contrast injection, ultrasound well shows enhancing nodule and irregular septa, so now it is Bosniak class 4 cyst and was a cystic clear cell renal cell carcinoma. This is an article comparing contrast-enhanced ultrasound with non-enhanced CT and contrast-enhanced CT in complex cystic renal masses. They described internal architectural pattern in benign and malignant lesions and reported that contrast-enhanced ultrasound was much better than non-enhanced CT and contrast-enhanced CT in demonstrating these patterns of internal architecture. Here we should keep in mind that positive enhancement does not always indicate malignancy. It means that there are benign tumors having similar enhancing internal architecture. Here is an example of a 38-year-old woman, a large cystic mass with abundant thick internal septa without prominent flow signal. Contrast-enhanced CT shows enhancement of those thick septa, and contrast-enhanced ultrasound well shows bubbles flowing into those thick septa. If we apply these patterns in previous article, it probably belongs to this pattern of malignancy. But this was a case of multilocular cystic nephroma, a benign tumor. So again, please remember that positive enhancement does not always indicate malignancy. Here are two more articles reporting that contrast-enhanced ultrasound can improve diagnostic accuracy of Bosniak classifications in complex cystic renal masses. Now following indeterminate cystic renal masses, let's move on to indeterminate solid renal masses. Here the most important issue is differentiation between angiomyolipoma and renal cell carcinoma. If we Google angiomyolipoma versus renal cell carcinoma imaging, there are about 80,000 results. There are so many articles regarding this differentiation using ultrasound, CT, and MRI. And I would like to introduce a couple of articles using contrast-enhanced ultrasound. This article included 126 renal lesions, 93 renal cell carcinomas, and 33 angiomyolipomas. They reported that if the mass shows heterogeneous enhancement, early washout, and perilegional rim, or pseudocapsule, it is much more likely a renal cell carcinoma than angiomyolipoma. So, this hyperechoic mass shows heterogeneous enhancement and early washout. It was a renal cell carcinoma, but in this hyperechoic mass, enhancement is quite homogeneous and not washed out early and was an angiomyolipoma. This article dealt enhancement pattern at contrast-enhanced ultrasound. They classified enhancement patterns as diffuse homogeneous, diffuse heterogeneous, peripheral nodular with quick or slow central fill-in, and dot-like, and found diffuse heterogeneous enhancement pattern was most common in renal cell carcinomas, while dot-like enhancement pattern was most common in angiomyolipomas. This is a case of renal cell carcinoma in that article showing diffuse heterogeneous enhancement, and this is a case of angiomyolipoma showing dot-like enhancement. Here is another article published in the Korean Journal of Radiology reporting diagnostic value of quantitative and qualitative analysis of CEUS in hypoechoic renal masses. They compared the CEUS findings in 174 hypoechoic renal masses, including 32 angiomyolipomas and 142 renal cell carcinomas, and they found that centripetal and homogeneous enhancement with tumor-to-cortex enhancement ratio lower than 91% were highly specific findings for angiomyolipomas. These are cases in that article. This is a case of epithelioid angiomyolipoma with 61.7% of TOC, tumor-to-cortex ratio, and this is a case of clear cell renal cell carcinoma with 178.1% TOC. Finally, I would like to mention briefly on pseudocapsule. Pseudocapsule is fibrous tissue and compressed renal parenchyma around the mass. It means that the mass grows slowly and the mass is easy to remove because of the barrier around the mass, and its presence suggests renal cell carcinoma rather than angiomyolipoma because usually angiomyolipoma is soft and does not produce pseudocapsule. These are two different cases of clear cell renal cell carcinomas, and both renal masses show pseudocapsule of low signal intensity at T2 weighted MRI. They show different degree of enhancement as CT. There are articles reporting that contrast-enhanced ultrasound is good at demonstrating pseudocapsules. In this article published in Italy in 2004 by Assenti et al., pseudocapsule was present at pathologic examination in about half of 26 renal cell carcinomas. They reported that only about 20% of them were demonstrated at conventional ultrasound, but more than 80% of them were demonstrated with contrast-enhanced ultrasound. This is a case of renal cell carcinoma in this article. Pseudocapsule is not well seen at conventional ultrasound, but after injection of contrast, it is well seen as a hypoechoic rim in early phase, as a hyperechoic rim at late phase, and again as a hypoechoic rim after high mechanical index flash. And these are two articles from China published in 2010 reporting similar results of demonstration of pseudocapsule in about 80% with contrast-enhanced ultrasound. This is a case from our hospital. At CT scan, pseudocapsule is not well demonstrated around this heterogeneously enhancing renal mass, but at contrast-enhanced ultrasound, the pseudocapsule is well seen as a hypoechoic rim in early phase and as a hyperechoic rim in late phase after contrast injection. On the basis of these CEUS findings, we may suggest that this mass is more likely a renal cell carcinoma rather than angiomyolipoma, and it was confirmed as clear cell renal cell carcinoma. So, this is a summary of my talk. Most of the problems we are facing in the evaluation of renal masses are differentiation of cystic renal masses among Bosniak class 2, 2F, and 3, and differentiation of solid renal masses between renal cell carcinoma and angiomyolipoma. Usually those problems can be solved with CT or MRI, but contrast-enhanced ultrasound may be an excellent alternative in patients with impaired renal function, and even contrast-enhanced ultrasound may be a problem-solving modality if we have problems at CT or MRI. Thank you for joining this session, and please email me if you have any questions.